సెకండ్ అదే కొట్టినా రాదు లాస్ట్ టైం. రైట్ రైట్ అమ్మ తీసుకో. Okay, today's class is about bronchitis, which is very commonly asked question. And so bronchitis is two types. One is acute bronchitis, and second is chronic bronchitis. Acute bronchitis of very short duration, a week or 10 days, and chronic bronchitis, if bronchitis is present more than 3 months, then we call it as chronic bronchitis. So, which can be chronic obstructive pulmonary disease also can occur due to bronchitis, emphysema, and asthma. Also, may be the complication of chronic bronchitis. Then you have this characterized by presence of flow obstruction. There is difficulty in breathing and caused by emphysema, chronic bronchitis, and generally it is progressive and may be accompanied by airway hyperreactivity, and may be partially reversible depending upon the condition. Then you have abnormal permanent enlargement of the air spaces distal to the terminal bronchioles, accompanied by obstruction of bronchioles. ఏడైంది ఇదేదో వచ్చింది సడన్గా, అటువంటిప్పుడు ఏం చేయాలి? బ్రాంకైటిస్ మాట్లాడుతున్నా, ఏం చేసినావు? ఏంటి
పక్కన కొట్టింటాం సార్, ఇలా కొట్టడం పక్కన కొట్టేసి పోతుంది.
అవును, ఇది పెద్దగా కావాలంటే ఏం చేయాలి? స్క్రీన్ పెద్దగా,
ఈ పదం
ఏది ఇక్కడ అది నొక్కాలి,
ఇది నొక్కితే చిన్నగా అయ్యింది, అది నొక్కితే చిన్నగా అయ్యింది, మనం ఇంకోసారి నొక్కామనుకోండి పెద్దగా అయ్యింది.
ముందు పెద్దగా. సో So the abnormal permanent enlargement of the air space distal to the terminal bronchioles results in emphysema accompanied by destruction of bronchioles, the mucous membrane and the musculature will be then you see the muscle contraction and the mucosal edema, sticky mucus will be present in bronchitis. You see, one is the sticky mucus and then it becomes mucosal edema and then muscle contraction will be abnormal. Goes into spasm, and whereas you see the normal bronchial transaction which will have a greater lumen than the bronchitis patient. You see the normal bronchial tube with a good caliber of the bronchi, and then you see the abnormal bronchial tube with full of muscular hypertrophy and narrowing of the lumen on the affected side. Then you have the COPD, the chronic bronchitis, going on to COPD, which the major causes which will contribute for COPD. One is bronchitis, asthma, or any other allergic bronchitis, and hereditary or alpha-1 antitrypsin deficiency produced by liver and found in lungs accounts for about 1% of COPD cases. The emphysema results from lysis of lung tissues by proteolytic example enzymes from neutrophils and macrophages. Usually the emphysema results from lysis of lung tissues by proteolytic enzymes from neutrophils and macrophages. Then the types of bronchitis, the chronic bronchitis and acute bronchitis. There are two varieties of chronic and acute bronchitis. The chronic bronchitis is a chronic inflammation of the bronchi of medium-sized airways in the lungs. It is generally considered one of the two forms of chronic obstructive pulmonary disease, the other being emphysema. Chronic bronchitis is defined clinically as a persistent cough that produces sputum and mucus for at least 3 months as a year in 2 consecutive years. Produces sputum and mucus for at least for 3 months per year in 2 consecutive years. We will call it as chronic bronchitis. Then the signs and symptoms. Bronchitis may be indicated by cough, also known as productive cough. And they have shortness of breath and wheezing. Occasionally the chest pains, fever, fatigue or malaise may also occur. Mucus is often green or yellowish green in color and also maybe orange or pink depending on the pathogen causing the inflammation, and the severity of inflammation is also important. The causes are tobacco smoking is most common cause, pneumoconiosis and long-term fume inhalation of the other causes. Other fume inhalations also can contribute. Allergies can also cause mucosal hypersecretion, thus leading to symptoms similar to asthma or bronchitis. Due to smoking, pollution, air pollution, and smoking can cause COPD. Chronic bronchitis pathophysiology. The pathologic lung changes or hyperplasia of mucus secreting glands in trachea and bronchi, increase in goblet cells, disappearance of cilia, chronic inflammatory changes and narrowing of small airways. So altered function of alveolar macrophages infection. Then you have chronic inflammation, that is due to it's a primary pathologic mechanism causing changes in the narrow airway and in lumen and reduced airflow, hyperplasia of the mucous glands, inflammatory swelling, excess thick mucus, and then you have the greater resistance to airflow increases work of breathing because air has to pass through a narrowed bronchial tree. The hypoxemia and hypercapnia develops more frequently in chronic bronchitis than in emphysema. So the cough is often ineffective to remove secretions because the person cannot breathe deeply enough to cause airflow distal to the secretions and into the alveoli, and the bronchospasm frequently develops, more common with history of smoking and asthma. Then you have the earliest symptoms, the frequent productive cough during winter, frequent respiratory infections. Then you have bronchospasm of end of paroxysms of cough and history of smoking, and the normal weight or heavy set, and ruddy bluish red, bluish red appearance may be present. So polycythemia, the increased hemoglobin per deciliter, and chronic emphysema and cyanosis may be present. So then the diagnosis can be made by physical examination, by puffiness of the eyes and cyanosis, reddy bluish coloration of the face and the eyes and the mucous membranes and auscultation. You can find scattered rolls and bronchi depending upon the bronchitis and secretions logging in the bronchial tree. The diagnosis, a variety of tests may be performed in patients presenting with cough and shortness of breath. The pulmonary function test with a spirometry, A chest X-ray, chest radiography, a sputum sample showing neutrophil, granulocytes, inflammatory white blood cells, and a check for pathogenic microorganisms such as Streptococcus species, and a blood test would indicate inflammation. High resolution computed tomography. Then you have COPD and its complications like pulmonary hypertension, pulmonary vessel constriction, alveolar hypoxia leads to acidosis in these patients because of retention of hydrogen ions which are not properly excreted through the breath. Then they can have pneumonia, and acute respiratory failure also can result due to COPD. Then you see acute bronchitis is an inflammation of the large bronchi, medium-sized airways and in the lungs, that is usually caused by viruses or bacteria and may last several days or weeks. Characteristic symptoms like cough, sputum, phlegm, contraction, shortness of breath and wheezing related to the obstruction of the inflamed airways. The diagnosis is by clinical examination and sometimes microbiological examination of the phlegm. The treatment for acute bronchitis is symptomatic as viruses cause most causes of acute bronchitis. The antibiotics should not be used unless microscopic examination of gram-stained sputum reveals large numbers of bacteria. The anti-inflammatory drugs, steroids, may be tried, and the arachidonic acid, which inhibit the COX-2 inhibitor, like the toricoxib, and there will be leukotriene secretions and which will produce histamine-like substances which will produce bronchospasm in these individuals. The steroids also can be tried as an anti-inflammatory, life-saving when the patient is acutely ill. Take at least 12 hours to work, so start early in severe cases. Systemic steroids, acute severe asthma, and inhaled steroids maintenance can be tried. Anti-inflammatory drugs, steroids, systemic steroid is intolerance and Cushingoid features, hypertension, salt and water retention, infection, topical steroids. Anti-inflammatory drugs, cromoglycate, mast cell stabilizer, prevent release of histamine from mast cells by inhaler only. And useful maintenance therapy, release of histamine, we can try useful maintenance therapy with the steroids or cromoglycate mast cell stabilizers can be tried, and no role in severe episodes. The few, if any, adverse effects are present. The anti-inflammatory drugs like leukotriene receptor antagonists like arachidonic acid and leukotriene, which will act upon the leukotriene receptors. The prostaglandins with gastric protective effects. Arachidonic acid will act, which is an anti-inflammatory. The leukotriene receptor antagonist. And then you have prostaglandins with inflammatory effects. Anti-inflammatory drugs, leukotriene receptor antagonists, like leukotrienes cause capillary leakiness and bronchoconstriction, used orally for maintenance therapy. Montelukast, added with inhaled steroids, and then bronchodilators can be tried, like alpha receptors. Alpha receptors will vasoconstrict receptors and their effects. The beta-1 receptors increase heart rate. Beta-2 receptors produce vasodilatation and bronchodilation. Beta-2 receptor agonists. They are adrenaline will act upon alpha, beta-1, beta-2, which will increase heart rate, increases blood pressure, and it dilates the bronchi and bronchioles. So noradrenaline, which will act upon alpha and beta-1, which will noradrenaline will decrease the heart rate, increases the blood pressure. Dopamine, which will act on alpha and beta-1, increases heart rate, increases blood pressure. Isotretinoin, beta-1, beta-2, and it increases heart rate and blood pressure may be normal or decreased. The salbutamol, which will act upon beta-1 slightly, beta-2 mostly, and which increases the heart rate and dilates the bronchi and bronchioles. Then you have beta-2 agonists like salbutamol, terbutaline inhalers of various types and maintenance regularly in more severe cases. The acute severe asthma and tachycardia and tremor. So Aminophylline is not a catecholamine but has analogous effects and a narrow therapeutic range and given by mouth or by intravenous infusion. Toxic if fatal if injected too fast, convulsions and tachyarrhythmias. Antimuscarinics like atropine is the classical antimuscarinic and this is a bronchodilator. Atropine too many and diverse effects like antimuscarinics or atropine is the classical muscarinic and this is a bronchodilator. Atropine too many adverse effects, ipratropium by inhaler added to salbutamol and can produce a dry mouth. So this is about the bronchitis and antibiotics for the infection depending upon the patient's organism that has grown in the bronchial secretions.